We always use guidelines to help us determine ways to control cholesterol and, in order to prevent cardiac disease. So in 2013, the ACC and the AHA made another recommendation of an algorithm that looks at a number of risk factors to determine if a patient should be on a cholesterol medication or a statin. In clinical practice, we will often use these algorithms to help determine a patient's risk factors for developing heart disease, to help determine if they should be on a cholesterol medication, and in general to use it as a tool to inform the patients of the risk factors and to have a discussion with them as to what the best treatment is for their heart health.
In my clinical practice, I still use targets. That is not what the ACCIAHA guidelines say, but the National Lipid Association says that we should still be looking at targets. The consistent thing with all the guidelines is to pick an appropriate statin at an appropriate dose for the patient in front of you. One of the reasons that the ACCIAHA guidelines, when they came out, did not address targets was that there was really very little evidence that adding anything to a statin reduced cardiovascular risk. Since those guidelines have been published, we have new data showing that adding Zetia to statin therapy is beneficial in very high-risk patients. So in very high-risk patients, I might choose to add a second drug, particularly Zetia, to get them to particular targets.
It's been really hard for people to stop treating to target. That's a well-established practice with a lot of research behind it, and folks find it really hard to break that habit. Along with treating to target is tracking LDL levels. Now that's something that as a medical director you can very easily track and report on to your providers. So not doing that becomes a little bit more of a challenge. However, there is a new risk stratification tool that the new guidelines recommend to use. And that's something that we can track and that I found that a lot of providers are using. It allows them to really see both the 10-year and the lifetime risk for most of their patients, which is something that we really didn't have before.
I'm absolutely initiating lifestyle interventions. This is very important to my clinical practice and many other doctors' clinical practice. If you actually look at the guidelines and the criteria that set up the guidelines determining one's 10-year risk factors and determining whether you should be on cholesterol, they have several things: blood pressure, cholesterol history, smoking, and a lot of these things we can control with lifestyle alone and without medications.
Eating right, exercising, and taking care of yourself goes way beyond just preventing disease. It certainly does those things, and we're talking more about than just heart disease. We're talking about stroke, your energy, your bone density, your stress levels, how you feel, how flexible you are. All of the things that we talk about in terms of living the correct way have an impact. And so it's beyond what we would measure on a blood test. I mean, yeah, I want your cholesterol to be better. And yes, we don't want to have major diseases as you get older, but it's good to feel good now and establish those habits because you get a tremendous number of benefits that your doctor can't measure.
I think in terms of mainstream clinical medicine that I practice, we are going to be much more influenced by guidelines than by emerging therapeutics. We have a massive bedrock of information on cheap and effective and safe medicines, namely statins. And the newer therapeutics that are evolving are extraordinarily expensive and really best left to those patients who have very extreme cases.
I haven't used any of them. They're very expensive. My patients are going to be reluctant to use them because of that. They haven't been proven to lower risk of cardiovascular disease, although they have been proven to lower LDL. So I'm probably going to be a late adopter of that drug just because I want to see evidence that this drug is going to help patients before I prescribe it. There are some side effects. There may be some neurocognitive side effects with this medication. And so I really take to heart, do not cause harm to the patient. So I would wait until this medication proves itself as actually reducing cardiovascular risk, and then I may use it for patients who I can't get their cholesterol down or are very high risk for cardiovascular disease.